You have to check out these knots. I was working on a lady's back today and I found knots all over her lower back.
This is one of the biggest scams. The scams that we've invented a lot of treatments for things that might not exist.
Hello everyone, I'm Colin and welcome back to Picking Apart Scientific Studies for my own fun and probably very little profit. Today I want to talk about the big trigger point debate. Here's my regular disclaimer that I am not an expert in science or medicine. I'm just interested in medical controversy. Ever since I did my deep dive on lipedema and discovered it should be thought of as a chronic pain condition, I've been fascinated with chronic pain as a concept. Specifically, how much we don't know about it. A while ago I made a video all about the strange world of myofascial release, which is a type of physical therapy with incredibly pseudoscientific origins. We, as a society, were so blessed that a mastodon died and then was reincarnated into a Native American warrior who then died and was reincarnated into a very silly white man named John Barnes. That's his story anyway. That deep dive introduced me to the concept of myofascial restrictions. Basically, John Barnes thinks that chronic pain, or basically whatever ails you, is caused by tightness or restrictions in the fascia. I didn't come across very much research even defining myofascial restrictions, because it turns out that term is very John Barnes specific. But I did come across a very similar concept: myofascial trigger points. I think Barnes likely borrowed from that concept. But even though trigger points are much better researched and more widely accepted, there are still a lot of problems that it shares with the concept of restrictions. Actually, I wrote a whole spiel in the myofascial release video all about the various controversies and debates surrounding trigger points, but it felt like a little bit too much of a tangent, so I cut it out. Also, I just didn't feel like I had a deep enough understanding yet, so I just kind of implied there were issues there and left it vague. It's been quite some time since then, and I feel like I have a slightly better grasp on trigger points, but I'm still a little undecided about what I believe. It's kind of frustrating because for both of the longer video essays I've made, I didn't feel confident enough to finish them until I'd reached some kind of conclusion. So I'd like to approach this video as kind of an exploration of the debate, just so I can exercise the trigger points demon from my brain. The most important thing to know is that the girls are fighting, and personally that's the thing I'm really into. First of all, what are trigger points? Great question. It depends on who you ask. I feel like I've been saying that a lot lately. We could go all the way back to Dr. Janet Travell, arguably the founder of the modern trigger point theory. She coined the term and popularized the concept in the 1940s and 50s. In 1983, Dr. Travell and her co-author Dr. David Simmons wrote the first trigger point manual, where they defined a trigger point as, quote, a hyperirritable spot usually within a taut band of skeletal muscle or in the muscle's fascia. The spot is painful on compression and can give rise to characteristic referred pain, tenderness, and autonomic phenomena, end quote. Sounds pretty reasonable, until you start asking some pesky questions, like what are those spots? What causes them? And how do you know they're really the cause of pain? Like I said, that book was published in 1983, but it's since been updated several times because there has been a lot of scientific advancements since then. Today you'll most often hear doctors and manual therapists define those hyperirritable spots as nodules or knots within the myofascial tissue. And there's a lot of speculation about what causes them. Acute injury, repeated strain, lack of oxygen, or maybe an inflammatory response to those things. And I think a lot of people would hear that description and say, how is that controversial? Everyone knows about muscle knots. Massage therapists and physical therapists always tell you what terrible knots you have in your back or your neck. And treatment is supposed to relax and release those knots, right? Well, the answer to that question, it turns out, is that we just don't know. And I happened to come across a video by a chiropractor and a physiotherapist's response to it that I think perfectly demonstrate the problem.
You have to check out these knots. I was working on a lady's back today and I found knots all over her lower back.
This is one of the biggest scams. Just watch how many treatments claim to fix a knot.
So I decided to do something different. We went with trigger point therapy and petrissage movements, massage the ball, tuck send therapy, which is hammer therapy. I proceeded with gua sha and eventually I moved in with active cupping.
The scams that we've invented a lot of treatments for things that might not exist, knots and trigger points. A knot is like a unicorn. We can all describe it, but that doesn't make it real. You can try and find one, but we don't have a reliable way to do it, partly because that knot can easily be normal tissues we've fooled ourselves into calling a knot. Kind of like in his most viral video.
Giving some trigger point therapy, watch what happens. Those are all the knots that he's carrying.
Those are pisogenic pedal papules, not knots. Secondly, we don't really know what we're looking for or what a knot even is. Here's what we know. People get sore spots. Sometimes rubbing it helps, sometimes it doesn't. We don't know what they are, if it's an actual lump, if the lump needs to disappear, if the lump has anything to do with it, if there even is a lump, if we can actually do anything about it, if it even requires treatment. We don't have those answers. So it's kind of weird that we sell treatments that we made up using those answers that we don't have.
Here's an interesting take on muscle knots or trigger points that's just popped up in my feed.
A knot is like a unicorn. We can all describe it, but that doesn't make it real. You can try and find one, but we don't have a reliable way to do it, partly because that knot can easily be normal tissues we've fooled ourselves into calling a knot.
So I think I can speak for most physiotherapists and other people who do massage as well. Once you've felt enough muscular tissue, muscle knots or trigger points become relatively obvious. Yes, they can be confused with things called lipomas, which are just little balls of fatty tissue, but if you're experienced enough, you can easily tell between the two.
We don't really know what we're looking for or what a knot even is. We don't know what they are, if it's an actual lump, if there even is a lump, if it even requires treatment. We don't have those answers.
In physiotherapy, a knot is relatively well understood, and while it's true there is often a lot of mystery around what's important and what isn't when resolving musculoskeletal complaints, one thing that we can all do a better job of is basing everything that we do on results. And when discussing whether trigger points are actually important to someone's pain or dysfunction or not, we can figure this out. For example, one of the most common places to find knots or trigger points is along the inside of a person's shoulder blade. And if you can locate a knot and apply constant gentle pressure to that spot, it creates a reflex in your brain that can instantly ask that knot to release. And if it does, it's most likely not anything else. And while I agree that there are a number of treatments that may not necessarily be effective, if we just base things on results, we'll very quickly understand what is helpful and what isn't. But ultimately, in medicine and healthcare, the language that we use matters. To suggest that we don't necessarily know what trigger points are, nor do we have effective treatments for them, unnecessarily clouds this conversation. And when we're dealing with pain and dysfunction, we ultimately need more clarity and more answers, not more confusion.
That was kind of a lot, and we will break it down, but the most important thing to take from this debate is that a lot of people experience myofascial pain, and quite often that pain is attributed to trigger points. But should it be? Some people who experience active chronic myofascial pain are actually diagnosed with a condition called myofascial pain syndrome. For most doctors, the identification of trigger points is required to make the diagnosis. And that feels like kind of a problem when experts can't even agree if trigger points are real, at least in the way they're commonly accepted. One of the major problems with trigger points is that there's currently no objective test to confirm them, no definitive imaging like MRI or ultrasound. Usually trigger points are identified by palpation. A practitioner will feel for a knot and look for a spontaneous twitch response in the muscle. And I'm not here to knock the doctors and manual therapists who diagnose trigger points that way. With enough education and experience, I think a lot of them could be pretty reliable. But I also think this diagnostic technique is inherently problematic. It leaves the door wide open for misdiagnosis, both for missing existing trigger points and inaccurately diagnosing them where they don't exist. I mean, like both the chiropractor and the physiotherapist pointed out, things like papules and lipomas are being misdiagnosed as trigger points by people who are supposed to be experts. That's part of the problem, but the other part, something else they both can agree on, is that we don't fully understand what trigger points are or how they function. Plenty of chiropractors, physical therapists, osteopaths, massage therapists, and other professionals insist they can feel the knots in the myofascial tissue, the knots cause the pain, and common myofascial treatments work. Unfortunately, though, some experts are very opposed to the trigger point theory, and of course there have been some pretty strong rebuttals in return. I'm not an expert, so I won't even pretend to know everything about the debate, but I will attempt to steelman both arguments. Big thank you to Paul Ingram, the writer of PainScience.com, for breaking down the debate in his article, Trigger Points on Trial. He looked at two papers that illustrate the problem in detail. The paper positioned against trigger points is called A Critical Evaluation of the Trigger Point Phenomenon by Drs. John Quintner, Jeffrey Bove, and Milton Cohen. And the response to it is called A Critical Evaluation of Quintner et al., Missing the Point, by Drs. Jan Dommerholt and Robert Gerwin. These papers are a little less snappy than YouTube Shorts, but I'm hoping my dazzling wit will keep you engaged. So Quintner's group points to the lack of scientific evidence that myofascial trigger points exist in the way they're commonly described, as palpable nodules or knots in the muscle that cause chronic pain. One of their issues of the theory is that there's a lack of consensus about how trigger points should be diagnosed in the first place. It seems that palpation of the muscle is actually not very reliable, despite education and experience. Quintner's group references a few studies looking into diagnostic agreement between practitioners, and the results vary quite a bit. It seems when practitioners are told beforehand where the patient experiences pain or where to look, they are able to arrive at the same diagnosis independently. But when practitioners are completely blinded to the diagnosis, they aren't able to agree nearly as often. So there's controversy about whether these muscle knots can even be reliably detected. But that's only one piece of the puzzle. More importantly, there's also conflict about whether these knots are the cause of pain, or maybe the byproduct of something else. Quintner argues that the trigger point theory is a circular argument. His rather dismissive description of the theory is, quote, "Trigger points cause myofascial pain because painful muscles contain them," end quote. Quintner argues that this is an example of the fallacy post hoc ergo propter hoc, which means because thing B happened after thing A, then thing A must have caused thing B. One example I saw of post hoc ergo propter hoc was, "My dog barked and then lightning struck, therefore my dog barking caused the lightning to strike." And we can't prove that isn't the case, but there are plenty of reasons to believe that it's not. In the case of trigger points, because practitioners can often feel a knot in a painful muscle, they think that knot must cause the pain. There very well could be a cause and effect relationship between trigger points and chronic pain, but we just don't know that for sure. Maybe a muscle knot is a response to something else. Maybe whatever causes the pain also causes a muscle knot to form. Maybe it's even a coincidence. Honestly, in my opinion, it's hard to even call this an example of post hoc ergo propter hoc, because who knows if the pain or the knot developed first. Proponents of trigger points usually say the knot develops first, but how could they determine that? Usually people seek help for pain. They might not even notice or care about a muscle knot that isn't painful. And that's not even a hypothetical scenario because there are muscle knots that aren't painful. Some people have knots that are completely asymptomatic. Some people have ones that are only painful when you press on them. Proponents of the trigger point theory call those latent trigger points, whereas trigger points that are constantly painful are called active. The idea is that latent trigger points could eventually progress into active trigger points and vice versa, but like I said, I feel like that would be extremely hard to determine. I think the chance that someone would catch a non-painful knot and see it develop into a painful knot over time would be extremely slim. And it also complicates the whole trigger point theory. How can we say someone's pain worsened because a muscle knot worsened? How can we determine a cause and effect relationship when we can't even determine what exactly a trigger point is or what it does? And that's if we can accurately diagnose it in the first place. Well, on the other side of the debate, Drs. Dommerholt and Gerwin argue that trigger point theory isn't so much a theory as it is a hypothesis. So when Quintner's group says there's no consensus about what trigger points are or how they should be diagnosed, Dommerholt and Gerwin say, yeah, we never said there was. And they also argue that Quintner's group uses outdated studies to make their case, while much more rigorous and recent studies better support the idea of trigger points. Despite all the arguments, everyone can agree that myofascial pain exists. People like Dommerholt and Gerwin propose trigger points as a possible cause, and treatments based on the hypothesis seem to help, in some cases better than placebo. Dommerholt and Gerwin place their emphasis there, on the treatments. That's the same argument given by the physiotherapist we watched earlier. Why muddy the waters when the treatments are working? Shouldn't our focus be on those people who are in pain? In a lot of ways, I can understand that argument. The most important thing is treating people's pain. So even if this trigger points hypothesis turns out to be incorrect, we don't necessarily need to throw away treatments like myofascial therapy or dry needling if they're really effective. A lot of treatments originated with hypotheses we no longer accept, but the treatments still work. For example, we don't fully understand why SSRIs work because most scientists now reject the chemical imbalance theory of depression. But we do know they work for a lot of people, so we continue to use them. As Paul Ingram concludes in his article, Quintner's group pokes a lot of holes in the trigger point theory, or hypothesis, but it's premature to disregard the idea entirely. There seems to be too much evidence to throw it away, but not enough evidence to say it should be accepted as fact. I will say, as much as I've come to admire Paul Ingram, and you should definitely check out painscience.com, I came away from the argument leaning way more towards Quintner's side. Paul seems very neutral on the subject, and I think that's a reasonable stance. He's a former massage therapist, and I'm certainly not an expert on any of this stuff. I can only draw my conclusions based on my limited understanding of the evidence. In my opinion, having read both papers, some of Quintner's group's conclusions do seem too premature. For example, they say, quote, "The theory of myofascial pain syndrome caused by trigger points has been refuted," end quote. And I personally think they should avoid that kind of definitive language at this stage of the research. And like I mentioned before, Domerholt and Gerwin argue that Quintner's group uses outdated studies in their paper. I have to agree, a lot of the studies are quite old. They wrote their paper in 2014, but they reference studies from 1992, 94, 2000. That doesn't mean those findings are wrong, but typically you want to use the most up-to-date research available to make your case, because science is ever evolving. They do use some current studies as well, but I do think it's a valid criticism from Domerholt and Gerwin. But I also think Domerholt and Gerwin make some pretty bad arguments that not only diminish their own argument, but bolster Quintner's. In their refutation, Domerholt and Gerwin say, quote, "Quintner et al. Claim that the concept of trigger points is a prime example of circular reasoning. Trigger points cause myofascial pain because painful muscles contain them. Their argument can easily be applied to other tissues. For example, arthritis in the knee causes knee pain because some painful knees are arthritic," end quote. Basically, they're saying Quintner can't call this a circular argument because then he'd be calling other types of pain circular arguments too. The problem is they're comparing apples and oranges. Arthritis is a general term for joint disorders for which there is accepted and well understood pathology. No one claims there's this entity in the joints called arthritis that causes pain. Arthritis describes disorders of joint inflammation and degeneration. It's very clear how and why those things cause pain. But some people are saying trigger points cause pain without good evidence as to why that would be the case. There's not yet an agreed upon mechanism behind why knots or nodules would form and why they would cause pain. Domerholt and Gerwin also cite a couple of papers that I don't think back up their claims in the way they say they do. They criticize Quintner's group for using outdated sources, but then they cite a paper by Gerwin from 1997 claiming this paper shows that trigger points can be identified by ultrasound. I wasn't able to find a copy of this paper, and it turns out other researchers had trouble locating it too, but I did find out it was a case report, which is a report on an individual patient, not a study. And even more damning, I was able to find a paper that referenced this report, and this is what it says. Quote, "Gerwin not only did not identify a hyperechoic trigger point, as others have erroneously referenced, but despite the title of the article, did not image a myofascial trigger point at all. What he identified in his image was, in keeping with some of our images, a hypoechoic taut band," end quote. Not to mention, Gerwin himself has refuted the claim that ultrasound can detect trigger points. In an editorial from 2017, he says, quote, "The most useful objective test to identify the trigger point is high-definition ultrasound. However, ultrasound does not reflect the presence or absence of pain. Ultrasound may be used to confirm that there is a taut band in a particular muscle. However, even then, the use of ultrasound cannot confirm that the taut band palpated is the taut band imaged. There remains no clinically useful objective diagnostic test for the identification of the trigger point other than palpation of the muscle," end quote. Sure, this editorial was written a few years after critical evaluation of Quintner, but it wasn't because there was any new evidence overturning his findings from 1997, because his findings from 1997 were not what he claimed they were later. Domerholt and Gerwin also claim, quote, "A recent study confirmed that a systematic musculoskeletal evaluation can distinguish patients with active trigger points from subjects with no pain," end quote. They cite a study by Gerber et al. From 2013. I looked at that study, and the systematic musculoskeletal evaluation in question was mostly, drumroll please, palpation of the muscles and questionnaires about the subject's symptoms. What's bizarre to me is this study did mention that both groups were evaluated with ultrasound, but there was no discussion of the results. Not to mention, there were several subjects in the no pain control group who had asymptomatic muscle knots or latent trigger points. Great control group. So what actually distinguished the subjects with pain from the subject with no pain was not the existence of trigger points, but the subject's overall health status, including disability, range of motion, and mood. The Gerber study does seem valuable, just not in the way it was cited. The examiners looked at under-evaluated symptoms associated with myofascial pain syndrome, but they weren't necessarily trying to figure out a cause. I feel like Dahmer-Halt and Gerwin using the phrase systematic musculoskeletal evaluation is a little wiggly, let's just say. I'm no scientist, but that phrase makes me think of something more objective, like imaging. Also, to refute Quintner's claim that the trigger point treatments were indistinguishable from the placebo effect, Dahmer-Halt and Gerwin say, quote, "The double-blind controlled dry needling study by Mayoral et al. Demonstrated clearly that the treatment of trigger points was superior to placebo, but this innovative study was either overlooked or conveniently left out of the paper," end quote. That's a pretty strong accusation, so I looked at that study, and I think there's a major problem with it. So dry needling, if you aren't familiar, is a treatment where needles are inserted into identified trigger points. The theory is that the needle can relax the muscle and stimulate blood flow. It's called dry needling since it's just a solid needle and there's nothing being injected. The Mayoral study looked at two groups of patients about to undergo knee replacement surgery. After being put under anesthesia, but before the surgery, one group was dry needled and the other group was not. So because they were under anesthesia, none of the patients knew if they received dry needling or not. This was an attempt at blinding to account for the placebo effect. The study found that the patients who had dry needling had way less pain 1 month after surgery than the patients who didn't. But the pain levels in both groups were about the same at follow-ups at 3 and 6 months. On a surface level, that seems like a decent study. Maybe dry needling could give these patients an extra boost of pain relief directly after surgery. However, here's the major problem. Yes, the patients were under anesthesia when they were dry needled, but that doesn't necessarily mean they didn't know after the fact. From what I've read, dry needling can have side effects, usually soreness or bruising. Sure, maybe the dry needling group didn't have those side effects, but we don't know that. The paper doesn't say. But I feel like if I were in a study where I was told you are either going to be dry needled or not, and we're not going to tell you what group you're in, and I came out of the surgery with soreness or bruising in my previously identified trigger points, I'd assume I got dry needled. And couldn't that create a placebo effect? The idea that I got some extra treatment versus none? I do agree that Quintner's claim that trigger point treatments are indistinguishable from the placebo effect doesn't seem to be accurate, but I also think Dahmer-Halt and Gerwin are overstating their case by referencing this innovative study. Dahmer-Halt and Gerwin make the valid criticism that Quintner's group uses outdated studies, like I said. But it's also a problem to use current studies that don't prove the things that you're saying they do. And it would also be a more valid criticism if there weren't more recent studies that still provide similar results to the old ones that Quintner used. In another article on painscience.com, Paul Ingram points to another study from 2012 which showed that palpation may not be very reliable. In that study, 2 doctors with manual therapy training were asked to identify on which side of the body patients experience pain. Paul writes, quote, "In almost 200 patients, they identified the correct side of 65% of lower back pain and 59% of neck pain, barely better than chance. The results are obviously underwhelming. Although they did a little better than just guessing, the results suggest that it's difficult, even for expert examiners, to detect the location of neck and back pain by feel. As well, they were only attempting to detect the side of pain, kind of the palpation equivalent of hitting the broadside of a barn in target practice," end quote. Obviously, a big problem with this study is that it only included 2 doctors. But these 2 were supposed to be experts, and considering the only reliable diagnostic technique for trigger points is palpation, it doesn't look good. So what does it mean that various practitioners aren't able to agree on a diagnosis? Isn't a trigger point supposed to be a palpable muscle knot? How could they miss that, or what else could they be feeling? Well, there's a psychological phenomenon called pareidolia, where humans tend to find patterns or faces where they don't actually exist, just because our brains evolved to seek those things. I'd only heard of this concept in reference to sight, like seeing objects in clouds or seeing Jesus on toast, but it can also refer to touch. Physiotherapist Adam Meekins wrote an editorial titled "Soft Tissue Sore Spots of an Unknown Origin," where he explored his own experience with pareidolia. Or rather, lack of experience. In spite of his extensive training as a physiotherapist, he has never been able to confidently identify a trigger point by feel. He admits that it might just be a skill issue, but he also points to research that suggests some practitioners may only feel trigger points because of pareidolia. In other words, they already know where the pain is located because the patient obviously tells them, and since they expect to feel a knot there, they do, even if there actually isn't one. This isn't always the case, but I think it's important to keep in mind. Human beings are extremely fallible, so we probably do need more objective tests for trigger points, which we don't currently have. And if we want to talk about the recency of the research, Paul Ingram's article about the Quintner debate was written in 2024. He also has a more in-depth article detailing the issues with trigger points as a whole from 2023. Paul was a massage therapist for a decade before becoming a science writer, and he even wrote a whole book about trigger points. But he still has doubts. I think it's really telling that there are people like Paul Ingram or Adam Meekins or the chiropractor Aaron Kubal from the beginning. People who are educated and have worked in the field of manual therapy for so long, who just aren't confident that the commonly accepted idea of trigger points is accurate. It's also telling to me that some of the fiercest proponents of trigger points, like Domerhalt and Gerwin, still hold that it's merely a hypothesis. I think there is a way to view that as responsible science. You don't want to make a claim without strong evidence to back it up. But in my opinion, calling trigger points a hypothesis just looks like backpedaling. Elsewhere, they both discuss trigger points as if they have intimate knowledge of what they are and how they function. I think their insistence that trigger points are a hypothesis could be a way to brush off valid criticism like Quintner's. Something else that's fascinating, I found out that both Domerhalt and Gerwin were closely associated with Dr. Janet Travell, the founder of modern trigger point therapy. She mentored Gerwin, and he even appeared in Dr. Travell's educational series called The Trigger Point Tapes from 1990.
The examination of the individual with chronic pain demands a laying on of hands, because you cannot appreciate myofascial pain, you can't palpate trigger points unless you actually put your hands on the muscle and palpate. That's a very intimate contact with the patient. And patients invariably tell me that, and they will often tell me that this is the first time they have been examined in any detail. The patient develops a great deal of confidence in the practitioner who knows how to examine and who can find the spot. When you find a trigger point and a taut band and you get a local twitch and you say to the patient, "Does this hurt?" And the patient says, "You have found the spot." And then you show some more interest and you say, do you feel that pain elsewhere? And the patient says, "Yes, it travels right up my neck." And you say, "Is this the kind of pain that you've been having?" And the patient said, "How did you know?" You have made a contact, and you've shown the patient you have an understanding, you have an interest. It is a real part of the art of being a physician. And I think that the examination becomes therapeutic in this sense.
That sounds pretty definitive for something that's supposed to be just a hypothesis. Domerhalt and Gerwin are also co-founders of MyoPain Seminars, which are, you'll never guess, seminars on how to treat myofascial pain. Fun fact, MyoPain Seminars used to be called the Janet G. Travell MD Seminar Series, and she often attended the seminars herself in the 90s. Now, this can mean two things. Number one, Domerhalt and Gerwin are extremely knowledgeable. They have extensive hands-on experience, they teach, and they themselves were taught by the founder of the concept of trigger points. Maybe knowing that, we should respect their authority on the subject. But on the other hand, number two, it can also mean they're extremely biased. Dr. Travell was a pioneer in the field of chronic pain, yes, but we know so much more now than we did in the 1940s or even the 1990s. And because we know more, we know there's a lot more we don't know. Basically what I'm saying is that it's been decades upon decades, and we still haven't budged beyond calling trigger points a hypothesis. Even the people who promote the idea and the treatments the hardest. Part of me wonders if some people cling to this hypothesis because of that bias, or because they just don't have a better explanation. I can sit here and blather all day about the papers I've dug through and the inconsistencies I've found, and all that stuff is very important, but what's more important is how these studies affect real-life treatment. I feel like I spent way too little time talking about the physical therapist Walt Fritz in my myofascial release video, because I like him a lot and he's really changed the way I think about research.
But for a new clinician who's tasked with trying to read a study and figure out, okay, I'm supposed to follow this, but how can I when it's non-followable? I think it really makes it not just challenging, but impossible for us to really take this home to each and every patient. What am I getting at with this video? Number one, there's a lot of good studies out there, but number two, they're really difficult to translate into practice. And I think the onus should be on these researchers, should be on the people who are writing these papers and editors of journals to take a look at these papers and say, can we really expect that someone can follow through on these procedures based on what was written in the study?
Yeah, sure, trigger points are a hypothesis, but what are practitioners supposed to do with the patient suffering with myofascial pain? No matter what you want to call it or where it comes from, we still need to treat people. Because all you have to do is search up trigger points on YouTube or TikTok and you will find 8 quadrillion different physical therapists, massage therapists, chiropractors, whatever, all with different ideas about what trigger points are and how to deal with them.
All right, today, Brad, we're going to talk about the big lie about trigger points, which you might know as knots.
Right.
What we believe, in our opinion, in most cases, even though you're having trouble in the muscle, it's coming from like the neck or the spine.
So she has something called a trigger point in her neck. Instead of kind of going like this and going, trying to get the knot out, it would be very painful. So with the trigger point, you get right on it. It's like a little knot. You get right on it and you just hold it. Just hold it. So I'm keeping that pressure and eventually it'll melt away.
Pelvic pain is something that has many different causes, but oftentimes women that have pelvic pain will have what's called trigger points, which is a hyper-irritable muscle fascicle. Basically, it is a knot within that muscle. Specifically, muscles in your pelvic floor are the levator ani, and obturator internus is a deep one, deep inside, that is associated with pretty much all pelvic pain.
What actually is a muscle knot or a trigger point? The truth is, we don't know. Like, there's tons of debate around different theories, but we don't know if they even exist. Which is crazy, because everyone's heard of trigger points and muscle knots, and we have treatments that rub them, stab them, and scrape them. But when you look at the actual science, it's a mess.
If you want lifted open eyes, you have to get rid of tension in the SCM. As you can see here, the SCM is a trigger point muscle, so it sends off tension and pain to this area of the face.
And how is the average person supposed to sift through all of that? It's even worse when you realize, like I did, that quite a few of those videos are just nonsense, at least based on the research that I've done. Like lumping all pelvic pain into a possible trigger point issue, that feels alarming. And what on earth is a trigger point muscle? That's just nothing. Not to mention the blatant misdiagnosis of pisogenic papules on the foot as trigger points from earlier, and all of the weird, unproven treatments some of these people are trying. Lest we forget that most of these people on TikTok or YouTube pitching you their trigger point therapies are doing just that. Pitching. Because they themselves are physical therapists or chiropractors or dry needling practitioners. That doesn't mean advertising therapy on social media is always wrong, but it does mean that there's a stake, and it's especially concerning to me that there's so much apparent misinformation about this stuff circulating. I'm not surprised, just disappointed. And I think it's fairly obvious why that's happening. It's exactly what that physiotherapist Grant Frost said at the beginning, or what Robert Gerwin said in that video from 1990.
To suggest that we don't necessarily know what trigger points are, nor do we have effective treatments for them, unnecessarily clouds this conversation. And when we're dealing with pain and dysfunction, we ultimately need more clarity and more answers, not more confusion.
The patient develops a great deal of confidence in the practitioner who knows how to examine and who can find the spot.
Patients want to feel confident that their doctors and therapists know what they're doing. I think it's weird for Grant Frost to say it's unnecessarily confusing to suggest we don't know what trigger points are, nor do we have effective treatments for them. Because that's just the truth. We don't know what trigger points are. And we might have effective treatments for pain, but it would be premature to say that those treatments specifically target trigger points. Because again, it's the truth that we just don't know. Which means for probably the first time in my life I can say I agree with the chiropractor. As for me personally, I would much rather have a doctor or a therapist tell me the truth, that they don't know for sure, but they can try something to see if it helps, rather than someone telling me very confidently that they know exactly what's wrong and how to treat it, when that's just not the case. Alright friends, thank you once again for coming along another trip down the rabbit hole. It's kind of grueling to sift through papers and try to make sense of them as a non-expert, but I do find it fulfilling and I hope you got something out of it too. Oh, and I should also say a big thank you to getting me to now over 10K subs. That's wild. There are so many of you. Honestly, I can't think about it too long because it'll stress me out. That's so many people. But thank you so much. It really means a lot to me. And as always, if you like my content, don't forget to like, comment, and subscribe, and I will see you next time.
Bob and Brad, the two most famous physical therapists.